So I do have one relevant disclosure, which is I helped NuVasive design a cervical cage implant for which I receive royalties. So let's talk a little bit, just review the anatomy of the cervical spine. As I'm sure you all know, there are 7 cervical vertebrae, and they're connected to each other through several joints. There's 2 facet joints, one on either side in the posterior aspect of the spine. And then we have the disc, which is also a joint. And then the supporting structures, which are the ligaments. And then inside of this spinal column, we have the neural structures, the spinal cord and the nerve roots. So the discs have basically an annulus, which is this outer part of the disc, which you see there on the right side. It looks like a radial tire. It has all these different lamellar rings, and they're oriented in horizontally cross orientation to each other. It's a very strong part of the structural part of the disc, and then inside, sort of like where the jelly would be inside of a jelly donut, you have the nucleus. And a lot of patients think it's actually like a gel. It's not. It's really, the consistency would be more like tough crab meat, really. And the annulus and the nucleus both contain all the compounds that you see on the left side. And the real difference is the composition and proportions. So the nucleus has a much higher water content than the annulus, and that gives it its sponginess, its shock absorbing ability, and so let me go back here one second. And so the discs are probably 25% of the height of our entire spine column. It's our major, shock absorbing ability for our body. The discs also have poor blood supply. Really, things get into and out of the disc through osmosis more than real blood supply. So injuries to the discs are hard for the body to repair. Infections, very difficult to eradicate inside a disc just because of this poor blood supply. So what are the things that can happen to the disc? One is over time, as we age, the discs lose water, and this is very easy to see on MRI. On a T2 signal MRI, you can see that the loss of water is very apparent, and by the time we're in our 40s, sometimes in our 30s, we begin to see desiccation or loss of water content in the discs. And this results ultimately in loss of height of the discs. So the discs thin out, they lose height, and we begin to develop a bone spurring, and that's sort of a normal part of aging, and it's why we are all gradually and subtly shrinking over time. The other things that can happen, you can see in the bottom right, is that you can get a weakness in the annulus. And this is due to, again, loss of water content or trauma, which results in loss of integrity of the annulus, loss of elasticity, and resistance to trauma. You can get areas where it literally looks like a tire that's bulging out, or where you actually have through and through tears in the disc. Here you can see an annular tear. This white spot, which is called a high-intensity zone, is called an annular tear, and it's a sign that the back of the annulus is torn or damaged. And then through that, the nucleus can protrude or herniate and get out, and either in this picture, as you see in the bottom right, laterally towards where the nerve root is, or more centrally towards where the spinal cord is. And then in the top right, we talked about the degenerative process, where we have loss of height of the disc. And the body's response to that is to form osteophytes, to form bone, literally to try and bridge across the joint and stabilize it and ultimately fuse it. And sometimes we do see in older patients where discs have become autofused together. I won't cover the trauma and the infection aspects much here. I mean, those would, I think, necessarily dictate referral to a surgeon. That's not something that's going to be dealt with in a primary care environment. So what are the symptoms and signs of radiculopathy, which is where you have a nerve root that's compressed, where you have something off to the side laterally that's compressing the nerve root after it's, or right as it's exiting the spinal cord. And typically this would be the symptoms of pain, numbness, tingling, and weakness, and some combination of those. Frequently we see people who just have pain, and they don't have any of the others, and I think that's important to remember. There are obviously other reasons that someone could have pain in their neck and in their shoulder and their arm, There's a lot of overlap. We frequently see patients referred to us by the shoulder service because patients were sent to the shoulder service thinking it was their shoulder, and it's actually their neck, and vice versa. So we see people who come in thinking it's their neck, and we end up sending them to their shoulder surgeons to have them look at them. But you can see that there is a referral pattern for each specific nerve root, and this is not it's not as well demarcated in real life as it is in these drawings. Sometimes people complain, the symptoms are somewhat vague. It's hard to pin them down where the exact pattern is. I mean, sometimes they'll literally say it's radiating right down my radial forearm, right into my thumb and index finger. Okay, well, that's C6, but many times it's frequently vague description of where their pain is. We do see a lot of pain referred into the shoulder, scapula area, and that's very common. We see some patients who just have that. Actually, they don't have arm symptoms. We see a lot of people with pain in the trapezius and scapular area, as well as neck pain, and that's frequently a sign of a radiculopathy. Excuse me. And then you can have something that's compressing the spinal cord itself, which is called myelopathy. And that's usually not actually painful. Most people who have myelopathy don't have pain, and they don't realize they have it. It's usually it can be acute, but usually it's something that's very chronic and insidious in its onset, and people develop over time with gait problems, loss of fluidity of their movements, loss of dexterity, weakness, spasticity. A lot of times it's something that we pick up on exam, and the patient isn't even aware that they have something really wrong. So one of the first signs of that would be hyperreflexia, and we pick that up on exam, and the patient really doesn't have any symptoms. So we send people for scans sometimes just based on examining them and identifying this, even though the patient has no complaints. But as it gets further along, people do begin to notice, they're having problems walking, they're having problems getting up from a chair, their legs are not powerful, they can't climb stairs, they're losing their balance, they're falling frequently, and they're losing their hands are getting numb, they're having difficulty holding on to objects. Essentially, they're just getting clumsy. And so this is a sign of a spinal cord compression, which can be due to a disc herniation or due to bone spurs that have formed there. So what is the ladder, the non-operative treatment ladder that we use when we see these patients? So, well, first of all, we obviously do the workup and identify what the problem is and rule out these other possible etiologies. One of the things is just time. I mean, with someone with an acute disc herniation, frequently, more than half the time, in 2 to 3 months, this will get better on its own. So a lot of this is just palliating the patient as they go through time and heal themselves. And usually that includes medications, which would be the traditional anti-inflammatory, non-steroidal anti-inflammatory medications, muscle relaxers, steroids frequently. If it's an acute problem, if it's a more chronic problem, that's usually not going to be that effective, although we can try it. And then you have the neurotransmitter type medications like gabapentin, Lyrica, Cymbalta, and so this would be sort of our first line of defense, and encourage patients to do an exercise and stretching program. And then physical therapy and chiropractic treatment are very, very important. Particularly, I think traction helps a lot. In someone who's got a narrow foramen or something compressing their nerve root, some traction to alleviate that's usually very effective. And some people who get a good response go on then to get a home traction device of some sort and use that intermittently, because many of these patients do have recurrent flare-ups. Other modalities that are effective in therapy would be the electrical stimulation and ultrasound, and isometric exercises are effective, and I think also variable resistance exercises like the Medix machine I think are very effective. And failing all of these things, then we'll frequently send someone for steroid injections. As Dr. Barna, I think, has covered that quite completely. I won't go into that. There are times where we just reach the end of the ladder. We don't really have anything else, and that's when we start to think about surgery. And so usually, it depends upon when the patient's referred to us, but usually they've undergone some non-operative treatment for several months. It's rare for us to really operate acutely unless the person's just very impaired, disabled by pain, or has some significant neurologic problems that need to be remedied immediately. Usually we'll go through 2 to 3 to 4 months of non-operative treatment. So what are the indications for surgery? One would be, I think they fall into 2 compelling categories. One is pain that's really not responded to these other treatments, and that's most of the people. And then the other thing would be some type of neurologic deficit that's not improving or is worsening. And that depends, again, on the timing of when we see the patient. So someone who's got a pretty profound neurologic deficit early on, we might operate on them earlier than someone who's maybe got something more minor. And then instability. So if we identify that there's some type of actual structural instability there, that obviously is something that would be indicated for surgery. And then there's sometimes we see people that don't actually have any symptoms, and their exam might be fairly normal. Maybe they have some mild hyperreflexia or something that we could probably watch, but at times the risk of a neurologic impairment left untreated is too significant for us to just avoid doing anything, and so then we recommend surgery. So there'd be someone who comes in with very severe spinal stenosis, cord compression, and or if we see someone who's got a lot of atrophy, for instance, in their limb from a radiculopathy. So the approaches for surgery would be essentially, two categories: anterior going through the front, posterior going through the back. The anterior options, and this is probably in this day and age, the vast majority, probably more than 95% of the surgeries are being done through the front of the neck. Historically, before the advent of this anterior approach, maybe 50, 60 years ago, the surgeries were done almost all through the back of the neck, but that's more rare now. And so you have fusion. So on the left, you have a fusion where you basically go in there and you clean out the disc, you clean out whatever's compressing the neural structures, you clean out the bone spurs, and then you fixate in some way, either with some type of an implant in the disc space, some type of a cage or bone graft with a plate on the front, or a device like this, which has the screws that actually go right through the implant. We call that a self-integrated implant, and they both work very efficiently. They both have very high fusion rates and are very good outcomes. And then on the right, you see something that's been developed more in the last decade, 10 to 15 years, which is disc replacements. And we'll get into that a little bit more in just a moment. So for the fusions, we have, this is a very old operation. It's been done for decades. There is still some evolution going on in terms of the implants, but for by and large, it's a mature operation. It does address the pathology directly, which is why we like to go through the front, because usually whatever's compressing the nerve roots is impinging it from anteriorly. It's a highly successful operation. Outcomes are great, excellent fusion rates. The downsides are that we do develop adjacent level issues, which as you fuse segments together, most people ask, well, how much is my mobility going to be reduced? And it's actually very little. Most people won't notice. But the other discs notice, because now they're actually becoming hypermobile and they're taking on more of the stress. So they tend to wear out faster and degenerate faster, and we have adjacent level problems, and then people become repeat offenders, come back for more surgery, and then this loss of motion that we discussed. So the benefits of total disc replacement, which I think in most practices is not, there are a lot of people that come to us asking for that, when in reality, it's a small percentage of the people that it would be appropriate for. Maybe 10 or 15% of the people are actually candidates for total disc replacement. But when it is applicable, it's a very good option, because it allows them to have the retained normal range of motion and reduces the adjacent level effect that we talked about. They tend to recover in about half the time and get back to work quicker. I'm going to skip through this a little bit. The posterior approaches that we talked about are really more for something that's kind of far off laterally to the side, where it's not in front of the spinal cord itself, or someone who's got a multi-level problem that's really not very logistically feasible to do through the front because it's so many levels, and then we'll do like a multi-level operation through the back. So what are some of the acute post-op issues that we see that our rehab colleagues will sometimes be asked to help us address? And that's post-operative neck pain, which many people have. Is more common through the posterior approach. A lot of people do have paraspinous tightness and trapezius spasm. A lot of that's due to the facet, opening up the facets as we spread apart the vertebrae to work on them. Dysphagia, hoarseness, weakness. Sometimes people have postoperative weakness, which is temporary, needs to be rehabbed. And then this is standard. This is my rehab protocol, and this is somewhat variable. People do this different ways, but I think I tell people just normal neck movements. There's nothing you have to really do. Like people ask, how can I sleep? Well, whatever's comfortable, just normal neck movements, nothing extreme. Like you're not going on roller coasters, but you're just kind of dealing with life sort of normally. I don't brace people typically. I don't think there's any need for that with the current implants that we have, where they're quite secure in there. It's internally very stable. I usually recommend some type of limited lifting, particularly overhead, and limited like light activity initially, so avoid contact sports, but they can do low impact aerobics like treadmill, Stairmaster, elliptical, swimming, things like that. And then at some point in time, that gets advanced. So for a total disc replacement at 2 weeks, I start advancing their activity. By 6 weeks, they're back to normal activity. For a fusion, we really have to have that period of time where we want it to fuse. So that could be 2 to 3 months, depending on the patient, where we have them restricted from more than those other activities that we talked about earlier with the lifting. And I usually start therapy at about 2 to 4 weeks, depending on the patient. And this is really to address some of the postoperative neck pain, range of motion, and also strengthening. The only thing that would be different from the preoperative physical therapy would be that I don't like them to do traction, at least until we're sure that they're beyond that that period of time where whatever implants we've put in there have healed. And I think that's it. So thank you for your attention.